Good morning, everyone from the world. My name is Mengyu. I'm a hospitalist in Portland, Oregon, and today it sounds like uh, Ravi has an interesting case to present to the group. And yeah, Ravi, how would you like to us to discuss the case? You said do a pair like discussion.
Yes, Mengyu. Yeah, I'm absolutely stoked to have a brand new member who's appearing for the third time, I believe, to discuss a case. So Mengyu is one of our new members, and now is back from a whirlwind tour of China and other countries around China. Is now here today to discuss a case. But before we get underway, I want to ask if anybody has a case that they want to present. I do have a backup case, but if anyone has something that they've sort of brought along with them and would like to discuss. While we wait for that, how's the transition back been, Mengyu? How many days have you been back?
Like close to a week, I would say. Yeah, it's a lot of time zone, especially the kids. Like they cannot transit the time zone as easy as we. I mean, even for us, it's difficult. But it's really nice to be able to get back to the regular rhythm.
And tell us, oh, okay, Jasdeep has a case. Awesome. And tell us, you went to China and then you went, did you go to
Went to
any of the other countries around there?
I went to Japan for a week where I got to meet
Right.
Shunyao, which is the best part of that visit. Hi, Shunyao. I'm so glad to see you on video.
You're
Mm.
right. That was an absolutely fantastic picture, just seeing the both of you together. So wonderful, wonderful. Okay, so Jasdeep has a case, and yes, Austin, I saw your picture from Japan as well. So that was wonderful in those cutouts, right? So the one that you put on the chat.
Yeah, the
So
downtown is amazing.
yeah. So we'll be asking you, Mengyu, another time, what are the best places to go, and also Shanya in Japan. So hopefully go one day. And I guess we'll have Jasdeep present the first aliquot and we can display. I think, Mohammed, you're doing scribing teaching points. So one of you could deploy the whiteboard. Thank you.
All right. Scribe team, you guys are ready? Cool. All right, so this is a 65-year-old female that is presenting with 6 weeks of dry cough and 2 days of shortness of breath. Let me know if you want more, or if that's a good place to stop.
I think we could kind of think about it. What do you think? I'll let you start, Mengyu.
Yeah, I'll take a step. So when I first hear about dry cough, I have those like common things that comes to mind. Although like the addition of the shortness of breath actually makes it more concerning. I think as we learned in the past VMRs that would suggest more of a concerning process, especially in cardiopulmonary fields, and especially then if the patient has hypoxia, that would even more points towards the significance of the chief complaint. So again, for shortness of breath, I think central concern are a cardiac, pulmonary. I like to use the dyspnea framework, dyspnea pyramid to kind of organize my thinking around shortness of breath. I found that to be like visually easy to remember. But like for cardiac, basically everything that can lead to heart failure, but also like the physiology of the receptor like being so like J receptor being stimulated, like so MI, arrhythmia, and anything leading to heart failure would be the primary concern, including like pericardial process. And then for pulmonary, there's like multiple P's, and that in the background of dry cough, I would even maybe thinking more about like a parenchymal lung process. I mean, not necessarily. Maybe I'll stop here and see what Ravi thinks.
Yeah, absolutely, Mengyu. Some great thoughts. You sort of focused in on the two major organ systems where the predicament may lie. But I think at this point, it's sort of you want to start constructing a medical representation of the problem. So what is the problem right now that we're trying to identify? Cough right off the bat is usually could be non-specific, could be a trigger to something systemic, or it could be something localized, like you mentioned, in the lung. And then the shortness of breath also, that I think is the more alarming feature. But here we have somebody with shortness of breath for 6 weeks. So I'm still in the data acquisition mode. I want to know, like, when did it start? Did it ramp up? Is it the same sort of chronic intensity shortness of breath? What sort of things make it worse, make it better? And are there any accompanying sort of semantic qualifiers? So you want to do some more probing with some disease-related questioning. So I think the next aliquots will help us. But right now, front and center, I'm thinking, like you mentioned, the heart, the lungs, but I'm trying to understand the greater process that's unfolding in front of our eyes here. Back to you, Jasdeep.
All right, great discussion by both of you. So let's get some more history. So the time period of this is basically December, middle through December, and the symptoms started closer to Thanksgiving, so American Thanksgiving, so November time. And she said she was in the normal state before that, and then it was until last Thursday when she started noticing, so like about a week before presentation, started noticing acute onset of chills. She woke up that evening in the middle of the night with a coughing spit, like a coughing fit, to the point where she started becoming short of breath as well. She kind of felt that laying flat made the cough better, but the following night had more episodes of shortness of breath and cough, and felt like she just needed to go into the hospital. She's unsure of whether she had a fever at home. She does not have anything at home to check it with. She denies sputum production, hemoptysis, chest pain, rashes, headaches, abdominal pain, or diarrhea. Like I said, she goes into these coughing fits, which are precipitated by trying to take a deep breath in. She complains of significant exertional dyspnea for the last few days. And she also feels that like going up and down the stairs would become pretty difficult, to the point where she starts asking her family members to grab things from the upstairs. Her dyspneic episodes, she describes them, are associated with a racing heart sensation, and her past medical history has history of rheumatoid arthritis, is on methotrexate and hydroxychloroquine, in addition to tocilizumab. She also has history of hypertension, hyperlipidemia, and CAD. She also has history of tricuspid valve regurgitation. And then in terms of medications, she is on amlodipine and hydrochlorothiazide. Her PCP stopped the ACE inhibitor about 4 weeks ago. When she came into the ED, they obtained a chest X-ray, which showed bilateral fluffy opacities in middle and lower lobes. And due to this finding, they started her on ceftriaxone and doxy. And that's the end of this aliquot. And just, sorry. Social history, there is some relevance. She has no travel recently, but she does have 2 parakeets that she obtained 10 years ago from Puerto Rico.
Wow, that's such a rich aliquot. There's so much information to digest. Ravi, would you like to take turns, or should I just go ahead first?
Yeah, I'll kind of we can alternate, but it was interesting. You've given a lot of data here, which we kind of have to sift through to see what is significant and can potentially could give us some pivotal points towards what may be going on with this patient. But I'll take some of that data. So it was interesting. So there's a lot of different things that you kind of negated there. There's no involvement of abdominal dysfunction, no skin related involvement. So that kind of takes out certain categories, autoinflammatory conditions, some conditions come with some infections, histoplasmosis, or even cocci. You could have erythema nodosum or things like that, but you don't necessarily have those go together. But then the positional, I think a couple of people had also mentioned this. Interestingly, the cough is better when you're lying down. I usually thought when everybody's had sort of a viral cough, you tend to lie down, and nighttime it keeps you up all night. So coughing fits at nighttime can be quite worse. Although you said at nighttime it's worse, but lying down the cough isn't as bad. So at this point, I don't know the significance about that. How heavily to invest some thoughts in that, if that would help us to pivot to some pathology. But I think in the social history is very important. I'm going to leave that to Mengyu. But past medical history, some people had sort of flagged, is this a patient with potential infection? And are we dealing with, you want to understand if this is immunocompromised or immunocompetent patient. So immunocompetent patients are usually able to prevent disease. They may get infected, but are able to wall off, say, a insult of, say, we've had a large number of cases of histoplasmosis, cocci, and so on. So you get granulomatous response. So you get a cell-mediated response and formation of these granulomas. So most patients are usually asymptomatic, but then you have immunocompromised patients that aren't able to launch a cell-mediated response and then end up having either localized infections, maybe within the lung, or disseminated infections. So infection is sort of, notice I'm mentioning front and center infection here. So infection is in the top of my list of potential disorders. I'm not going to break down what potential infections, maybe I'll allow Mengyu because of this this certain bird that's in the social history as well. But I don't want to also just maybe concentrate on just infections, but also autoimmune phenomena may also be at play here, and then also some chronic lung diseases. This is sort of a insidious sort of response. It's not something suddenly that happened like a pulmonary embolism, pneumothorax, something acute or hyperacute. This is something that's been sort of brewing for quite some time. But I'll land my plane there and allow Mengyu to maybe weigh in on what's going on.
Yeah. So I agree. So I think there are a lot of things in the past medical and social history that may be linked to the underlying etiology of this bilateral, lung infiltrates correlating with the patient's symptoms. I mean, although like bacterial infection, like CAP is like common things being common, I think have to also keep the differential broad. Like, for example, the birds, as Ravi mentioned, of course, makes me think of the specific like chlamydia, Cetacea, if I pronounce the name correctly, like as an etiology. I'm curious how long she's had this bird, because like the presentation, like this acute onset and it's almost like, and this this time course almost feels like some sort of trigger, like environmental trigger, that has led to this developing this condition. And this like coughing fits. Well, so yeah, I would say like for the birds, like birds' lungs, like hypersensitive pneumonitis is also like a consideration from like the birds like poops or things like that. Then the rheumatoid arthritis also caught my attention. I think it's definitely associated with like underlying interstitial lung disease, like even like acute interstitial pneumonia. It's as a possibility, although we don't seem to see like pleural effusion here. And the medications. Remember, did I hear it wrong? Like, is she also on some like tocilizumab or something, or just a methotrexate? I think methotrexate, like you can think it's associated with interstitial lung disease. although like I don't know if it's usually presents as more, I guess in this case is more subacute. But I would imagine on the X-ray it might have more interstitial distribution. And if the patient is truly on some biologic agents, that could also be associated with ILD, like more in a more acute fashion. But sounds like maybe the patient is not on ILD. Maybe I just sorry, it's not on biologic. That maybe I just heard it wrong. Yeah, Ravi, do you have anything to add?
Oh no, this is wonderful. You just touched on two domains, which I kind of sort of superficially maybe mentioned, but I think the inflammatory lung disorders, especially for this time frame of 6 weeks, definitely is something that you have to consider. Especially this patient's been put on antibiotics. You really need to think about infections like pneumonia. So if I had this patient starting antibiotics, I have a low threshold because the probability of pneumonia is quite high in a patient like this. This is an immunocompromised patient, so you need to start some sort of antibiotics in case it is a bacterial infection until the testing comes back and confirms or refutes a bacterial pneumonia. But at the same time, getting further imaging to see, and especially occupational exposure. So if this patient has had other sort of exposures, if this patient is on a farm, if the patient has had exposure to thermophilic fungi or things like that, even if bacterial infection can cause hypersensitivity pneumonitis. And then the other ones, I remember COP, so cryptogenic organizing pneumonia, is another one that we've had on pulmonary Monday VMRs, where somebody will come in with a flu-like illness, and then you get put on antibiotics, and then it doesn't get improved, and then the patients do end up having this diffuse or on-imaging interstitial infiltrate. So something also to consider. But I think acquiring more data to sort of further hone in on what may be going on is warranted at this time, because I don't know, there's so many different discussions that we've had, but I really don't have anything that I can really latch onto at this point. Anything else, Mengyu, before we swing the mic back to Jasdeep?
No, but I just really like Austin's comments in the chat about like differentiating the alveolar filling process, like blood, pus, water, and protein. Just organize the thinking that way. I was thinking about that earlier as well.
Back to you, Jess.
All right, great. You guys hit on quite a few of differential diagnoses that we were thinking of as well. So I'm gonna, for this aliquot, I'm gonna do some vitals and physical exam. So when we examined her in the emergency department, her temperature was 97.9, but that night she did spike up to 102.5. But her Tmax was that 102.5, and since that one episode, she was afebrile. Her heart rate was 80. Her respiratory rate would fluctuate between 18 to 24. Her blood pressure average was 100/56. And general appearance, she basically was in no acute distress, but was wearing 4 liters of nasal cannula of oxygen. And when we would have like a prolonged conversation with her, she would have to take multiple pauses in her conversation. And then crackles were noted in all lung fields bilaterally, increased work of breathing, and then cough every time we would ask her to take a deep breath in. Cardiovascular exam was basically the murmur at the left and right upper sternal borders. These are not new murmurs for her. Pap refill was 2 to 3 seconds, so mildly reduced. Abdomen was unremarkable. There was no midline back pain along the spinous processes, extremities, and there was no dependent edema. She did have significant swan neck and other joint deformities of the hands and feet that was associated with her rheumatoid arthritis, and there was no rashes that we were able to appreciate either. So that's the physical exam. I will give you guys some basic labs, and I'll pause there if that's okay. No clubbing, Austin. Question. So her initial labs on presentation, white count was within the normal range of 4.5. The differential was unremarkable, meaning it was just a left shift. There was no lymphocytes, no significant lymphocytes. There was no eosinophils or blasts or anything like that. Hematocrit was 35, which was in the normal range. Hemoglobin was mildly low at 11. She typically runs at 12.5, so not that bad. Platelets was a little low, 109. And I'll explain that in a second. So let me just give you the rest of the labs. Her CMP was basically, or her BMP was unremarkable, but the liver chemistry showed the following: AST of 120, ALT of 48, total protein of 5.4, which is low, albumin 3.1, which is low. Alk Phos was 76, the normal. INR was normal. Lactate was normal at 1.9. CRP was mildly elevated at 25. ESR was normal. Some history. So going back to the platelets. So about 2 weeks before her presentation, she met with a rheumatologist, and they decided to take her off the teclistamab because of the LFTs and the low platelets. So what the rheumatologist did was stopped both the methotrexate and the teclistamab, because at the time they were not clear if it was the methotrexate leading to the LFT abnormalities, or if it was the teclistamab. I'm going to repeat that because just to help out the scribe. So basically, when she met with the rheumatologist, they stopped the teclistamab, and this was about 2 weeks prior to presentation. And they also stopped the methotrexate. That's the end of the aliquot.
Wow, this is a very interesting case, and it's so eloquently presented. Thank you, Jasdeep. So maybe I'll take a step first this time. So I think going through the lab, I think what the time course Jasdeep was describing is really interesting. The fact that she already had these lab changes, sounds like, with the LFT elevation and platelet, I think that's what I also heard, is like being abnormal 2 weeks prior, which is already in the middle of her symptom starting. So I wonder if this is part of this presentation. And the fact, yeah, and so like, I wonder if these labs have changed in any way when the tocilizumab is stopped. Like, hasn't improved in any way, but it might be too soon to tell anyway. And I was like trying to read about any like tocilizumab associated lung disease, but also like the most significant symptoms, like the shortness of breath, is just actually started after the tocilizumab was stopped. So so there's a little bit reading and reflection for me there. And maybe actually I'll transition to Ravi to reflect on the rest of the information here.
Thank you. Great thoughts. You kind of were focusing on what I was also considering, this tocilizumab. Now, in thinking through or sifting through this data, I think we have to kind of take a step back. We've got a lot of different things to consider, and it's getting kind of overwhelming. So I think creating a meaningful medical representation at this point. Who is the patient? So a 65-year-old female with the 6 weeks of dry cough and 2 days of shortness of breath. So what's interesting there, just going back to the basics, and we don't want to commit a bias, something called base rate neglect, where what's common is usually common, like you had early on mentioned about base rate should be considered early. So the 2 days of shortness of breath, usually with pulmonary fibrosis, what the sort of a rule I heard was it usually happens for months. 6 weeks, awfully short. So I don't know if we really should be going in heavily on the IPF and so on. And then who is the patient, and the temporality of this presentation we've discussed with the 6 weeks and so on. And what is the syndrome? So syndrome is quite involved, but this patient having the shortness of breath, cough, and along the features of what's precipitated by it. But then the rheumatoid arthritis goes heavily in this, and that goes into the background of this patient. And then the biologic the patient is on. So tocilizumab actually does cause, it could cause IPF, but again, I'm not quite sure unless we do in testing high resolution CT. But an interstitial pneumonitis could be triggered by one of these MAB agents. So I've had many cases where I've been fooled by these medications. They can produce a number of different conditions, hypophysitis, adrenal insufficiency or adrenalitis, hepatitis, and even interstitial nephritis and pneumonitis, like I mentioned. So here we have some abnormalities in the liver, although more AST than ALT. And it's kind of too premature to maybe say there's some effect on the liver. But then I'm thinking about maybe this tocilizumab producing this. People had mentioned about methotrexate. Again, I think that would be kind of a long, arduous process and kind of short to have something like this. And then 2 days of shortness of breath, this would be a ramping up like months and months and slowly building up of shortness of breath rather than 2 days of shortness of breath. Maybe this, we think thought about pulmonary embolism. This patient of 2 days is enough to have maybe pulmonary embolism. So we have to think about the pulmonary vasculature as well. But diving back into the history in this rheumatoid arthritis, how about connective tissue diseases? We talked about infections. We talked about inflammatory conditions. How about autoinflammatory conditions? So a number of different connective tissue diseases that can manifest in the lung. So definitely getting an ANA rheumatoid has an effect, mixed connective tissue disease. You have the myositis related autoimmune diseases. So I'm forgetting, you can have polymyositis, dermatomyositis, you can have antisynthetase syndrome, a number of different ones where lungs can also be involved. There may also be some signal in the muscle as well, which we don't see here, but definitely getting ANA, CRP, getting some of those antibodies, getting a high resolution CT would be helpful in this case. Anything else you think, Menu? I'm kind of sort of rambling on there, but
yeah, I just while you're talking, I got to go into UpToDate and look up the medication tocilizumab. I don't see actually any significant like lung side effect being a major side effect, because I remember like TNF alpha inhibitor, like those would be more like associated with lung ILD, but maybe less so for tocilizumab based on what I just read. So, and plus the tocilizumab is used like every 4 weeks. So like just 2 weeks stopping, or maybe that means 6 weeks. Regardless, I think it's maybe too soon to be like, so I don't want to like anchor my thoughts, even though that is like, I thought about that, but I don't want to anchor it to the tocilizumab, or because on the other hand, like RA itself could be associated, probably more significantly associated with this kind of presentation. But I still agree, like with the fever and the infiltrates, I think especially with the fever and the exposure history, like infections is still higher up on the differential along with the RA associated lung disease. Yeah, so I think getting like all the microbiology studies would be helpful. I think if the patient fails to respond to the CAP treatment, then especially I feel like is it doxycycline or azithromycin that patient is on, would have more points toward like maybe needing a more like a definite source assessment, like with maybe then would argue against the chlamydia if the patient fails to improve with the atypical coverage. But yeah, I'll pause here.
Back to you, Justin.
Great. Some really great discussion. So for this aliquot, I'll give you guys a little bit of what happened in the hospital course. So like I mentioned in the earlier aliquot, that she was started on the ceftriaxone and doxy on day 1. She did improve over time. But because of her presentation being kind of not so like textbook for bacterial pneumonia, especially with no consolidation, we decided to stop the ceftriaxone but continue her on the doxy. And she continued to improve. She went from 4 liters of nasal cannula. Actually, so for the oxygen requirement, it went up from 4 to 8, and then eventually started coming back down to like around 2, about like 3 to 4. In terms of her workup, her CT scan was basically read as significant ground glass opacities in the bilateral lower lobes with non-specific inflammatory findings. ID was involved and they like to do, offered plenty of things to work up. So we got a urine histoplasmosis and cryptococcus antigens, which were both negative. We continued. COVID, RSV, influenza was all negative. Bacterial cultures were no growth to date. HIV was negative. And see what else we did. And the LFTs. So when she first came in, they were pretty elevated, but then they also started to downtrend as well. And what else did we do? And then we did also, because her, we also got a CTA just to rule out a PE, which was negative for PE as well. So that is the, and then we also got a mycoplasma IgM antigen, which was negative. So this is the last piece of information. The next aliquot will reveal the diagnosis. LDH was mildly elevated, Austin. It was like, I can't remember now, but I think it was like 220 or something like that. Spirometry was not done. We were thinking about doing a bronch, but the pulmonologist felt that because patients slowly started improving, that bronch, it would be unnecessary. So we didn't poke the bear too much.
I think I'll have a first stab at this. We'll alternate Mingyu, but it's interesting. So we have pretty much quite a bit of data in when we constructed our mental model of this case. We can pretty much toss out a number of different conditions that have negative findings. Although many times on VMR, we've seen urine histoplasmosis be negative, and then you have to do a serum antigen and then see it's positive. But then again, I think we can still put that on the back burner and start thinking about what's going on. What's interesting about, I don't know if this holds true, but this ground glass feature in the lower lobe sometimes could be indicative of things like NSIP, DSIP, pulmonary edema, aspiration. I don't know about hypersensitivity. Usually it's more central zone, and hypersensitivity, I think in the X-ray it was sort of like mid lobes, but here in the CT it's showing lower lobes. But I think Shunya had a great thought in the chat, like should we do a D-dimer? But in this case, I think PE was pretty high in the differential. Since you are getting a CT, you might as well, if the kidneys are normal, or give some contrast to look at the vasculature as well. So at this point, I think infection still kind of play. I do like this thought. I think Austin mentioned getting an LDH can sort of help to tip the scales in favor of something like PJP. Again, this is a patient that's immunocompromised, being on various different agents. So at least at what could be at play here, definitely fungal lung infections. Again, although we're not seeing signatures such as lymph nodes and high lymph nodes that are involved here. So various number of fungal infections can cause lymph nodes. Cryptococcal could manifest with a diffuse pneumonia, could have lymphadenopathy, histo, coxy, paracoxy. But then at least that could be a very easy place to sort of do a transbronchial needle aspiration and get some answers. But I think I like the thought about maybe doing a BAL, a bronch with BAL, like Jas had mentioned, that could help get us some more information. But Mingyu, what are you thinking?
Yeah, thanks for walking us through all the differential for like infections in immunocompromised patients. And I think what's really reassuring, maybe I think like reassuring or about this case is the fact that she actually improved on sounds like mainly doxycycline alone, to the point even pulmonologist was deferring a bronch. So I feel like this could be more supporting the possibility of atypical infection like chlamydia, like the birds associated with parrots. So I wonder if if there's are like specific tests sent for that study, either from the sputum or like a serology, that would confirm if that's the etiology. Because I would think if it's rheumatoid arthritis associated lung disease, like you would still need some steroids to get better. And the patient seems to only got antibiotics and get better. So that is a very helpful information. So I would wonder if the patient has a chlamydia test for that specific.
I actually love that thought. Yeah, chlamydia, Sitachi, definitely. But you got a parakeet, so it makes it quite likely. Although I think we've developed a sort of a laundry list of different causes, but I think that's definitely in the running. And what I wonder, though, in this case, with the antibiotics, you suggest something very interesting. Is there's partial response there. What's interesting? Some of these antibiotics do have anti-inflammatory properties. So sometimes I've had patients where you get some sort of relief, but it's only because of some anti-inflammatory property, but it doesn't get you to full resolution of what's brewing under the surface. So sometimes you got to be careful. I know, like erythromycin has anti-inflammatory effects. Azithromycin has anti-inflammatory effects, some effects. So sometimes those can actually help, but won't resolve the process. And sometimes these patients do have some partial response and then discharge, only to go home and then get worse and bounce back in a much severe presentation. But back to you, Jess.
Excellent. So this will be the last, this will reveal the diagnosis, but before I do that, we did send an extended respiratory panel. We toyed with it a lot, just because I don't know if this is institution, but at least at our institution is pretty expensive. It's like almost like $2,000. But because her differential is so broad, we kind of felt like in her X-ray and CT findings could have been explained to like a viral pneumonia. We did get it. It was negative, all of it. I don't remember all of the viruses that were on there, but the entire thing was negative. I think I said this last time. I will say that the LDH was like very mildly elevated, but the beta D glucan was normal. So then we came into this little conundrum of like, what could this be? And I love this case because it really made you kind of think about the different possibilities, especially with her background being so rich. So we also had rheumatoid arthritis, like rheumatoid pneumonitis in there, but that wouldn't really explain like why it flare up now. I guess maybe because she stopped the medications that was on the differential. Yes, we did consider the parakeets and hypersensitivity pneumonitis versus psittacosis. She did improve with the doxycycline, and doxy treats all sorts of atypical infections. So could this be atypical pneumonia? We had PGP on the list initially because it was bilateral opacities, but the fact that we didn't give her Bactrim, I'm not too sure if Doxy has some activity against PGP, but considering she continued to improve and didn't look really sick and, didn't need to be intubated, we kind of felt PGP is also less likely. So the differential basically, and then the pulmonologist and the ID specialist were kind of going back and forth with what was going on. And the pulmonologist kind of felt that this was teclistamab-induced ILD. And the ID specialists were thinking that this was hypersensitivity pneumonitis secondary to the parakeets. And I'm sitting in there thinking, knocking on both of their doors, hey, the patient wants to go home. So what do we do here? We sent her home on 1 liter of oxygen, and the current differential was hypersensitivity pneumonitis and versus teclistamab induced ILD. And I put my money on the parakeets as well. But I followed up on their outpatient workup, and her CT improved. And the pulmonologist, when we discharged her, we did tell her the possibility that this could have been hypersensitivity pneumonitis. And she was absolutely not. Those parakeets are like my family. I'm not gonna give them up. So the fact that she improved, even though she went back home, and the pulmonologist, when she saw her in the outpatient setting, was more confident that this was teclistamab induced ILD. And
Wow.
I just want to quickly share a learning point that I had in this case. There were so many, but one that I definitely remembered was I know someone, I think it was Yaz, who mentioned psittacosis right off the bat, and that was me too. I was like, psittacosis, parakeets, it has, that. What I learned was most parakeets that are bought in the United States are not imported from outside countries. Therefore, they're less likely to have psittacosis. It is only birds that are imported from like South America where the chances of psittacosis is high. And that's it.
Very interesting there. I think earlier on you gave so much data and you presented so well. Do you present from memory, or was it probably wasn't even prepared? You just kind of spontaneously presented this case, but holy cow, there's a ton of data there to sift through. But notice there were like 2 features earlier on, both me and Mengyu had honed in on, which was the tocilizumab, so which I kind of call a pivotal point, which helps you maybe to get to some sort of diagnosis, although couldn't confirm it. It was nothing like I was like, oh, this is a slam dunk tocilizumab or slam dunk psittacosis or hypersensitivity pneumonitis. The thing that kind of goes against hypersensitivity pneumonitis, one is exposure. Number 2 is usually with removal of whatever is instigating it, it would get better. But this patient is still in the same environment, still has the parakeet. And like you just mentioned, these parakeets likely, unless they're reacting to something from the bird, she still has the bird and she's better. So I really can't say, but the tocilizumab is interesting. I did a quick Google that it can cause a like a cryptogenic organizing pneumonia. So something like that. Although with that severe steroids, I know in hypersensitive pneumonitis you may have to give steroids. This patient's oxygen requirements were quite high, and she did have imaging. So then it's still kind of a toss-up. I really can't say, but I've got to learn about 2 conditions from this case. I'm glad to hear the patient is much better. Any reflections, Mengyu?
Yeah, I echo with you, Ravi. This is such an amazing case, Justin. This is like, wow, I learned so much from it. And I would have also thought it would be hypersensitive pneumonitis when the infectious workup came back negative. And so I really appreciate that you follow up on the patient and tell us, like, actually the patient symptom continued to get better despite being back to with her birds. And so I think that this is like a very interesting part, and yeah, I agree. I learned a lot from this case.
And we'll have Mohammed do the Tingy points to take us home.
Hello, thank you so much. That was a great discussion and a great case with so much to learn from. So we started with a patient who's 65 years old, female with rheumatoid arthritis on immunosuppressive therapy. And she presented with progressive cough and acute dyspnea. And basically we first looked at the dry cough basically with dry cough with shortness of breath would make us think of concerning causes other than when patients who present with dry cough alone. And then we spoke about clues from history about the cough, the character, the time, onset, exacerbating leading factors that could point to the underlying etiology, meds that the patient is taking, systemic versus local causes of cough, and most common cause of subacute cough, which is defined as more than 3 weeks, but less than 8 weeks, would be upper cough syndrome, upper airway cough syndrome, asthma, COPD, GERD, or combination of both such diagnoses. Other causes would include infections, post-infections, obstructive sleep apnea, non-asthmatic eosinophilic bronchitis, chemical irritants, laryngopharyngeal bronchitis, bronchiectasis, and also some other causes. And then we thought of the dyspnea that the patient is presenting with. Again, we approached it as the dyspnea pyramid to identify the causes of shortness of breath. So we thought of causes in the lungs, including airway causes such as asthma, COPD, bronchiectasis, alveoli, whether it's water plus or blood. And then we spoke about parenchymal causes such as ILD, and then also vascular causes such as PE, pleural causes such as pneumothorax or pleural effusion. Diaphragmatic weakness also could lead to dyspnea. And then other causes in the heart, myocardium, heart failure, or basically pericardial effusion, tamponade, and other causes of dyspnea in the dyspnea pyramid include chest wall abnormalities such as basically kyphoscoliosis. Neuromuscular causes would include myasthenia, GBS, and lastly, metabolic causes such as acid-base disturbance or anemia. And then the immune status of the patient could help us in thinking about the type of infection that a patient could be having, whether it's a localized infection versus a disseminated infection in immunosuppressed individuals, such as this patient, and environmental exposures, occupation exposures, and medications that the patient is taking could also lead us to the underlying process or etiology of the cough and shortness of breath. And in such cases, sometimes we can order autoimmune workup inflammatory markers for connective tissue diseases, such as myositis, which can also present with pulmonary symptoms. And lastly, upon imaging of the patient, there was a ground glass opacity, which is non-specific and could be seen in infectious processes, chronic interstitial diseases, acute alveolar disease, or other causes. And finally, we basically the final diagnosis of the patient was the cough and the dyspnea was related to hypersensitivity pneumonitis or tocilizumab-induced interstitial lung disease.
Thank you, Mohammed. You nailed all the important points there. So really appreciate you presenting the teaching points so eloquently, as people have mentioned. And before we get going, I also, again, Jasdeep, thank you for such a great case. I'm going to think about parakeets all day long. But Deborah has an announcement for this evening's session.
Yeah, hi everyone. Thank you, Jazz, and Ravi and Maggie for all the great case. Yeah, just today we are going to have another episode at 7 p.m. AST of our project IMG initiated, and Dr. Andrew will be giving us some tips for application. So I want to invite you all, even if you are not IMG, it's tips for the match now. So we are all invited, and I hope to see you all there. So I see you all later. Bye-bye.
Thank you, Deborah. Take care, everybody. Bye. Bye, Mengyu. Bye, Jasdeep.
Bye.